All right, welcome everybody. We're going to go ahead and get started. Thank you for joining. For those who just joined, I see most of you put your information into the chat, but please be sure to do that. If you're just joining us, your name, your email, your organization, and credentials. We use that for introductions and to help with attendance. Today we have a presentation from Dr. Cody Smith around NAS. And then we'll have time for Q&A and any other questions the group might have. You can always put those in the chat. We will be monitoring that if the questions come up, but we'll try to hold questions until the end. And then when we do get to that point, you can unmute, use the raise hand feature, however you feel most comfortable asking questions. So without any further ado, Dr. Smith, I'll turn it over to you to share your slides and get started.
Perfect. Can everyone see my slides?
Sure can.
Okay, great. So I am an associate professor in the Department of Pediatrics at WVU. I am a neonatologist by training. So I usually take care of the kiddos who need, on the more severe side of things, that need medication. So that's kind of what I've been asked to talk about. Some objectives. I'll try to fly through some of this just for time's sake. But really, neonatal abstinence syndrome it's not new. It's been around for a really long time. The first case was described back in 1875, and the first case of treatment with morphine in a neonate was described in 1903. When we define, certain terms, this is one of my pet peeves. All the headlines sensationalize things in the news. Babies born addicted, yada, yada, yada. But babies are not born addicted. Babies are born physically dependent. They, were exposed to whatever substance while in utero, and they develop a dependence to that. So just a little pet peeve of mine. The CDC does have a case definition, but I will turn to our state's definition from the Project Watch that they created a few years ago. So they define or describe neonatal abstinence syndrome as a passive exposure of the newborn that occurs when a mother uses a neuroactive substance during her pregnancy. Oops. And so when that baby's born, that cord is clamped and cut. That infant is then deprived of that substance, and they can potentially have a withdrawal syndrome. Not all babies do. NAS includes neonate withdrawal from many substances, not just opioids. If it's an opiate, we now use the term neonatal opioid withdrawal syndrome, or NALS, instead of NAS, is what they like us to use. It is an exposure with clinical symptoms, so it's really a clinical diagnosis, and it's not just limited to those cases that require medications to treat. Some of the signs and symptoms that we see in these kiddos varies from neurologic to autonomic to GI dysfunction. Some of the neurologic signs that we commonly see are tremors or jitteriness. These kids, especially when disturbed, will shake. Rarely do we see seizures. Those are kind of super severe cases. I don't think I've ever seen a baby seize, honestly. I think it's because we're better at identifying in treating these kiddos. They don't sleep well. They're very irritable. They have high-pitched cries. Their tone's very high. So if you lift them up, most babies have a head lag. These kids do not. They're just like stiff as a board. They're like in a constant planking position, which can't be comfortable. They have an exaggerated startle reflex. That's the Moro. They yawn and sneeze a lot. They usually breathe pretty fast. They get pretty sweaty, can get febrile even and hot. So if you overbundle them, they can get really hot, and that exacerbates their symptoms. Their skin's often mottled, or kind of have that lacy rashy appearance to it. They get nasal stuffiness, so it makes it sound like they're having trouble breathing. They have some GI dysfunction, so they can, they can puke, they can have poor feeds. Some kids just don't want to eat at all, and you have to feed them with a feeding tube temporarily. They have a lot of loose liquidy poops, which then leads to diaper rashes, which can be painful. They can have such poor feeds and loose stools that they get dehydrated. And a lot of them do have poor weight gain. In West Virginia, we've been particularly hit hard. And 1 in 8 infants has been described to be exposed in utero to either an opioid stimulant and/or cannabis, which is 10 times the national rate. And as you can see from this fairly recent map, there's certain areas in our state that are hardest hit. That bright red area in the northern panhandle, which is where I'm at today in Wheeling, up in Ohio County there. There's in utero substance exposure is 18.47%, NAS of 8.34%. Down in the Huntington area and Cabell, they were particularly hit hard too, but also out toward Berkeley, there some higher rates as well. But just in general, our state's very, very hit hard here. I like to throw this slide in anytime I have a talk, that we are required to notify CPS as providers whenever there's a prenatal substance exposure. But that does differ from existing legal duty to report suspected child abuse or neglect. These reports that we are placing to CPS shall not be construed to be child abuse and shall not require prosecution of the mother. That's exactly the opposite of what we would like to do. We're trying to help this mother-baby dyad. So how do we identify infants at risk? Well, we screen moms and we screen babies. In West Virginia, by state law, OB providers, family docs that are delivering are required to use the West Virginia PRISI form to screen, and there are substance screening questions on there. However, not everyone does use this, and we've been talking about how we can make sure moms are screened better. We also screen infants, obviously by talking to the parents, the mom, but also we can screen with a urine toxicology screen. We can collect meconium or the first poop from the baby to send off, and we can send a cord tissue screen. It's not cord blood, it's the tissue. Now, these meconium and cord screens will detect substances that are tested for from about 20 weeks gestation to delivery. So it's a big span that it's collected. And I say that because you might have a mom that's late entry into care, say around 20, 23 weeks, but then enters treatment and is doing well, but she still might screen positive for some of the more illicit substances, even though she's doing well in treatment. So it can be explained by how long these substances can stay in the cord tissue. This is that PRISI form, and it's hard to read, but in the bottom left-hand question, there's several questions that I think are based on the 4P screening tool at the bottom to help screen moms that might have substance use disorder. We do score babies if they're exposed to try to determine, how severe a potential withdrawal might be. And there's several scoring tools. This is just brief. The Finnegan scoring tool, or the modified versions of this tool, have been the longest, most widely used scoring tool created by Loretta Finnegan back in the 70s. It's like 20-something items that you can see here that the scores range from kind of 1s to 3s. The higher the score, the worse the symptoms are. In classical kind of NAS has been described as scores of 8 or more. But there's also been several studies that if you score normal newborns, they'll frequently hit 8. And so really no one really knows what the actual right score is. And it's also to start treatment. And it's also a bit subjective, some of these things. One person might score a 2 for, something like severe tremor versus a moderate tremor. It's a little bit in the eye of the beholder. So there's always some inter-rater reliability issues there. The newest kid on the block with a lot more studies, including a big multi-center clinical trial that was just published this past year, is the Eat, Sleep, Console tool, or the ESC tool. This was first kind of published in 2017 by Matt Grossman. They're up in the New England area. And it simplified the scoring for these children down to, can they eat, can they sleep, and can they console themselves in a reasonable amount of time. And there's a big focus on involving the parents in this scoring tool. And there's a big focus on using non-pharmacologic interventions to try to get these kids eating better, sleeping better, and able to be consoled. And those are listed at the bottom. And we're going to talk about some of these non-pharmacological treatments. The overall goal of treatment is to really enable an infant to grow and thrive, right? So we want them to feed and gain weight, because, you know, if they're eating well, gaining weight, that means their brains are also going to be getting fed and growing as well. Some of these kids they may need a higher calorie formula to help with that. Some of them might benefit from some of the more sensitive formulas, at least temporarily, when they're going through more of the withdrawal in the beginning. Withdrawal symptoms can last up to 6 months. So it's not something, you know, that once they're home, they still can have issues, you know, and they still need a lot of monitoring, a lot of growth checks, weight checks, things like that. You know, we want to prevent morbidities from happening. We don't see seizures a lot, but it's been described in the literature. We don't want them ever to come back to the hospital for withdrawal, for failure to thrive, poor growth issues, things like that. We don't want them coming back with non-accidental traumas as well. So we want to improve and monitor those family interactions and help where we can. And again, overall, we want to improve their outcomes, okay? You know, if we can, I think it's great if we can limit any additional exposure to medications if we can help it, if the kiddo's able to do so. And so back in 2012, the American Academy of Pediatrics put out the practice guideline. They're probably modifying this. There's since been another report out. It's not a guideline change, but there's some newer things out there from the AP to go off of. But the first line of therapy is non-pharmacologic therapy or measures, and that's what we should use first. The optimal threshold, that, remember how we talked about that Finnegan score, is not known. And breastfeeding should be encouraged if a mom's doing well in a program. Opioid replacement for the infants, if there's severe symptoms that you can't control with non-pharmacologic measures, is indicated. And we should observe these children in the hospital for 4 to 7 days. Some of the evidence-based non-pharmacologic care, meaning, you know, using means other than medications, that's been shown to be beneficial is breastfeeding, swaddling, rooming in with the parent or caregiver, certain environmental controls, and skin-to-skin contact. And so at our institution, we kind of, you know, and this isn't unique to us. These are used in pretty much everywhere that takes care of these children. But we kind of standardize our approach to these 6 basic principles of non-pharmacologic care. And that's swaddling, positioning, motion handling, oral stimulation, and environment stimulation control. And so briefly, swaddling, it can be very beneficial. I like to use thinner swaddles, like the muslin blankets are great because they're stretchy. You can get them tight through the chest, but they're also very breathable. Nowadays, the recommendation is to not swaddle the legs tight at all, to leave them very loose so that the hips can be not constrained, so that they can stretch, so that babies don't develop developmental hip dysplasia. But nice and tight through the chest is beneficial. And so here's a little picture of how, you know, one potential way to swaddle a baby. The C position, I like to think about this as kind of the fetal position, right? Babies in the womb, you know, protecting themselves, they kind of curl up, you know, and so it's really kind of rocking that bottom up and kind of bringing the head forward a little bit into a little bit of a C shape. This allows the baby to kind of like gather themselves into a midline position, and that can be calming for them. Um, and you can do this C position like while lying on their side, or you can try some tummy time too. If you're watching them. Now this isn't a position you want a baby in for sleep. You want a baby to stay flat on their back for safe sleep. But if they're being observed, you can put them on their side or their belly and see if that helps. Babies tend to love their bellies for a little bit of time, but again, this is to be used with extreme caution. Now, the C position, what I found most effective is best coupled when you do some motion with it and some shushing, some sounds with it. So I like the vertical rock with the C position, where you kind of fold that baby no C, rock them close to your body and shush real loud at first. You almost have to kind of like bring your stimulation up to their overstimulation and then calm, as they calm, you get quieter, rock a little slower, that sort of thing. And then different handling, clapping, so kind of patting the butt or their back, closeness to the body and containment. One of the ways I like to do this is put their chest in my palm of my hand, put their butt flat against my chest, and kind of pat their back or their butt. So that hits the closeness and the clapping and the containment all at the same time. Plus, it kind of gets them into that C position. And that they burp oftentimes because of the pressure on their belly, and it calms them very nice. So those are my two favorite ways to calm babies. And by and large, it's pretty darn effective. We like to use pacifiers in these kids. There is a decreased risk of sudden infant death syndrome in infants who use pacifiers. But that suck can also help calm the baby. And in terms of feeding, we kind of like let them feed on demand. Every baby has a different pattern, and they might have certain positions that they like to feed in too. We talked that some of these kids might benefit from a higher calorie formula, um, um, especially in those that seem to like have methadone. But I've also seen it in moms who are in buprenorphine treatment programs as well. And then there's, some people use more sensitive formulas, whether they're low lactose or a hydrolyzed protein formula, things like Alimentum, Sim Sensitive, those sorts of things, Total Comfort. And it seems to be beneficial, but there's not good studies to support it. And actually, one of the studies, which is listed there, the babies who got the sensitive formulas did worse. But I think it's because the babies who were doing worse actually got the sensitive formula. So it just looks weird, even though it's not. Dr. Sarjeta nationwide is like the national expert in GI stuff, all things GI in neonates. And he did an investigation looking at infants who had opioid exposure as a fetus, and looked at feeding difficulties in these children. Basically, if you think about kids that are exposed, their muscle tone's high. Well, some of their inside muscle tone's high too. Some of those pyloric muscles, things like that, can be on the high side. So there's been shown to have an increased resistance of this food movement through the intestines. He said, we know it's not reflux, so we shouldn't treat this with an acid suppression medication. And he further states, that acid's there for a reason. It's to help digest milk. It's also part of our immune system to help fight off infections. So these kids should not routinely be treated with antacids. And then the last one's controlling the environment. Trying to limit overstimulating this kiddo, like cool, calm, and collected environment, limiting the number of caregivers, being too loud, being soft-spoken more, is a more appropriate thing, those sorts of things. And then, we try to go over some of these caregiver quick tips with the families before they go home. There's the 5 S's, the happiest baby on the block kind of deal, swaddling, side position, shushing, sound, swinging, sucking, pretty much covered these things, but that's just an easy way to kind of think about what to do. Just some other tidbits here. The more consistent we can be, the better. So, if we're going to get breast milk, it's better if you have consistent breast milk. If having consistent caregiver, that sort of thing. Don't overheat, overdress the baby. Try to protect the kiddo from scratching themselves with mittens or socks on their hands. And then, just always practice safe sleep when the kids are sleeping and you're not directly watching them. Breastfeeding has the same benefits, and there's really no medication if mom is prescribed that gets passed into the breast milk. It's just the act of going to breast and or receiving a nice, gentle breast milk feed that's beneficial. And it has all the benefits that, come with getting breast milk, from, fighting off infection, easily digestible, good for brain development, all of that stuff. So these moms should provide breast milk. And so we counsel them that, hey, you're doing great. Let's work on breastfeeding if we can. Now, there's a lot of talk about marijuana in breastfeeding. The initial study from Dr. Hale said tons of THC gets excreted in the fat in the mom's milk. Well, he's kind of backtracked that. I still think that we counsel moms like, hey, can you stop using while breastfeeding? Can you at least cut back and not routinely use, if not medically indicated? It's a risk benefit. It can affect babies for sure. So the less exposure, the better. But I still think the benefits of breast milk, and a mom who maybe occasionally uses is still good, and still outweighs that risk. But you'll hear difference in opinions on that. So the secondary approach, if all of those things, you've exhausted them, the baby still has signs of severe withdrawal, we do use medications. We'd use them cautiously. So a lot of places still admit their babies to the NICU where they can be monitored. Some don't now, and there's a movement to care for these children in the regular nursery. An absolute indication for treatment is a seizure, which we hardly see anymore. A relative indication would be, not eating well, vomiting, diarrhea, poor weight gain, those sorts of things. But if their scores are high, or if they aren't eating, sleeping, or consoling well, and we've exhausted all those non-pharmacological treatment options, then we move on to medication. Now, the AP still recommends an opioid replacement for these children. By far, kids who are having withdrawal or withdrawing from an opiate. And so the two recommended treatments, medications, are morphine and methadone. Clonidine is also around, as in some places are using buprenorphine, and there's some research surrounding that. We tend to basically treat these kids inpatient only. If you send these kids home on pharmacotherapy, yes, it gets them home, but they stay on medication a lot longer because it's harder to monitor that wean at home. So really the recommendation is to get them, if they need medication, to make sure they're doing well off of it while in the hospital. So morphine is a natural mu-opioid receptor. It treats all aspects of opioid withdrawal. This is what we use at WVU in Morgantown. It works well. It's a shorter acting opioid that we've been very successful. Feel like it's a little bit easier to wean than methadone, even though you have to dose it more frequently in the beginning. Again, it's a narcotic, so you're exposing that baby to another narcotic. We usually start at a dose of 0.05 Q3 hours every 3 hours, mg per kg per dose, and then up or down, go up or down. So the goal is to capture the child's symptoms and then kind of stabilize them for 2 to 3 days, meaning you get them in a good place before you start the wean. So you find a dose that they're happy on, let them sit there for a couple of days, and then you start a wean, usually 10%. Some places do 15%, and there's actually some research surrounding this ongoing right now that we're a part of. Methadone is a synthetic mu-opioid receptor. It has a very long half-life. It is easier to administer because you administer it less often. Weaning might be a little more of a challenge. Some of the concoctions have 8% alcohol too, and they can have a variable half-life. There's evidence out there that maybe methadone is better than morphine, and there's evidence out there maybe buprenorphine is better than all. But the research isn't great, and they're small studies, and they're kind of not powered to really give us a good answer. Clonidine is the AAP's recommendation for second line therapy, meaning if you're on a morphine or methadone, you kind of have worked up on a pretty good dose of it, the baby's still doing bad, having issues, then clonidine is an adjunctive therapy. And it is the recommended second line agent from the AAP. It is an analgesic, it's an antihypertensive, and is used in ADHD. It's an alpha adrenergic receptor agonist, and it kind of works in the area of the brain that kind of gets overstimulated. I like this medication a lot. It tends not to oversedate babies like phenobarbital did when we use that. There's not a lengthy taper. It's pretty quick off. I can get babies home and taper this quickly at home and not worry about it as well. There's no alcohol in this preparation either. You do kind of just have to watch blood pressure. I've never once seen any issues with it, but we still watch for blood pressure issues since it's a blood pressure medication. Phenobarbital is still used, not nearly as often as it used to be. And it's an anti-seizure medication, and it can have some alcohol base, kind of high. And so we try not to use this because it has been shown to have poor neurodevelopmental outcomes, but we occasionally still need to use it as a third line agent. And then buprenorphine, just like in mom, sublingual, it's being studied. It's not recommended to use this as a treatment at this time by the AAP. There's been others that have been described, even within our state. Gabapentin has been used in kids who have been exposed to gabapentin or not. And Zofran is kind of a newer one. There's a study out there that looks like if moms got Zofran and babies get Zofran after delivery, maybe they're less likely to have severe symptoms. Not recommended yet, but people are looking at it. This is something that was first described in 2017 in that eSleep Consult paper by Dr. Grossman. It's as needed or PRN dosing. Basically, the way we used to treat NES when we started medication was we just started them on a scheduled every 3-hour taper. And so that means they're in the hospital for 2 or 3 weeks just tapering off this medication. Well, this group said, well, why don't we just give them a dose or two and see if we can just get them over the hump? And they found that it was successful in some babies. And so we started doing this in 2019. The paper they further came out with, which was also published in 2019, called a symptom triggered approach. But we've been successful with it. We trialed it in late 2018, rolled it out for every baby in 2019. And we found about 35 to 40% of babies, depending on the year, respond to just one or two doses of morphine rather than a long treatment, which means they're there a lot less. They get a lot exposure to medication. But it seems to just get them over that a little bit of a hump that they have. So this has been very good for us. Gets kids out a lot sooner rather than, like 2 to 3 week stay, they're out in about a week, So even if they got a dose or two of medication, we do observe them if they get medication for at least 48 hours though. So again, not a lot of research on that, but there's more coming out. And I think this is, really important. And how to engage with these families. It's so easy to pass judgment and reflect our own biases and judgments on families. But it's nice to reflect before you talk or interact with these families on your own emotions, reactions, judgments, behaviors, and intentions. Because we have to remember that the neural pathways that drive parenting and attachment are probably the same pathways that are negatively impacted or dysregulated by substance use disorder. And that parents in recovery really, are trying to be active. They, a lot of them want to be actively involved. And that active involvement can actually have the power to reset that reward system in their brains. So we need to provide, and try to be extra supportive and helping to navigate, kind of what these families need. And I think we're starting to do this better. I think there's still plenty of room to do this better, which is why I like to talk about it and just to bring light to it. We want to help them to be successful in recovery. We want to decrease stigma. It's still a significant barrier for those that are trying to seek help and support. And a lot of these parents struggle with how to parent, how to, some of the guidance of their, child guidance and discipline and how to parent. And so getting them parenting classes and things like that, there's more resources available out there. We need to break this intergenerational cycle that's been ongoing in our state. But that really requires nurturing the nurturers, the parents themselves. The single most important factor in a child's recovery from exposure during pregnancy to opioids um, is the qualifying of the nurturance of that child receives from their caregivers. How nurturing that environment is at home, and really our foster care systems too overburdened, our CPS systems very overburdened for this kind of quality, and we really should try to find a way to help these families to make them successful. And our families that we're talking to and dealing with have gone through an absorbent number of adverse childhood experiences, and being born substance exposed, whether it's prescribed or not, is kind of that child's first adverse childhood experience. Now what we do from there is what's most important, right? We help the child and we help the family unit. That's the ultimate goal, so that child goes through less of these ACEs, therefore breaking this multi-generational cycle. And I mentioned stigma, but these moms I've talked to them a lot. They feel a tremendous amount of guilt, surrounding this. And just even if they're in a treatment program, if their kids have any signs or symptoms of withdrawal, they feel terribly guilty. And it doesn't, these kids can have the same withdrawal on a prescription medication that they do on a non-prescription substance. It doesn't mean they're a bad parent or did anything wrong. It just is a genetic or an epigenetic cause of that child. And one child in the same family, in the same mom on the same dose of medicine might have withdrawal, and another might not. So there's a lot of reasons, and it doesn't mean there's anything new or different, right? So we need this multidisciplinary, collaborative, non-judgmental care approach to treating these families, and we can have a tremendous impact on that mother-baby dyad. And there's a little table with some stigmatic terminology. I find myself still using some of these, and I'm pretty sure I use some of these today. I'm not perfect. None of us are. If I recognize I've used one of these terms, I apologize. I say, I'm trying to get better, right? And that's all that matters. When you ask about stigma, these are the things that you hear from families or folks that are going through treatment. There's a nice online resource, just a shameless plug for West Virginia Impact. This is a developing online resource for families, providers. You can get connected with various services. And there's also some training sessions. These are all free at this website. And that is all I have. And I think I kept it to a reasonable amount of time, covering a lot of materials. So I want to leave time for questions.
Thank you so much, Dr. Smith. That was great. Yes, we'll open it up for questions and comments. Again, go ahead and unmute and ask your questions, put them in the chat, use the raise hand feature, whatever you are comfortable with.
Hi, Dr. Smith. This is Dr. Wonder Genius from Unicare Health Plan. As a pediatrician who does case reviews, I've noticed that we have moms who are users of marijuana, and some of the facilities are keeping the babies in-house for that 5-day watch for marijuana exposure,
Mm-hmm.
which can you comment on that? Because it doesn't really
Yeah.
tie in with opioid use disorder. And
I agree. Yeah, I agree with you. There's no withdrawal syndrome that has been associated with cannabinoid THC exposure alone, and so unless there's an opiate or another substance that might have a withdrawal symptom or syndrome associated with it, which opioids are by far what I would worry about. I don't really see the need to keep that baby for 4 to 7 days. I think the standard of care, as long as the social aspects of it get sorted out in a reasonable amount of time and the baby's eating well, doing well, I think they could probably go home in a normal infant newborn time frame.
yeah, yeah.
I agree with you.
Okay, my second question is, is there any predictive value in determining how long a baby who has had intrauterine exposure to opiates will develop NAS, and or how long their treatment could be? Because I've seen some babies who go home in 5 days, and I've seen some babies who end up at Lily's place for 3 months. And is there anything that we could look back on mom's prenatal history and determine, okay, well, she was on buprenorphine for 6 months during her pregnancy, or she was actively using a week before her delivery? Anything like that that has come up in literature that we can look back on and get an idea of who's going to stay longer and who's not?
Yeah, it's interesting. There are folks working on tools to help predict kind of whether that child is more likely to need a longer hospital stay with medication therapy. They're not perfectly validated. The one that comes to mind is from Tennessee. From Stephen Patrick, who does a lot of public health work in Tennessee, has developed a model. Again, he's still in the process of researching it, so it's not like I know about it just because this is kind of a small world and we all talk with each other. So he's working on it. I will say that there doesn't seem to be. It doesn't matter really kind of the dose. So people are like, oh, this mom's on this dose of methadone, or it doesn't really seem to matter the dose, the medication the mom's prescribed. I don't know. I don't know in terms of how long, the moms are on the medication for. I haven't seen anything about that. But a lot of the differences that have been described in infants, there have been findings of different genes that both in adults and in children that make them more likely to withdraw, as well as different epigenetic changes, which are basically these little signals that get turned on and off on certain genes that make them more prone to withdraw or not. So you could have a baby whose mom was in a buprenorphine treatment program the entire pregnancy. She has 2 children on the same exact dose. Nothing new or different happened. They're both born at the same age, around the same weight. One child could have severe withdrawal and the other might not. And it's probably related to whatever genes that child got from mom or dad and whether they're more likely to have severe symptoms or not. It's very interesting. And there's a lot of people looking at it. And there's more genes that are kind of found every day. So people are definitely interested in prediction tools. They're probably coming. They're just not mainstream yet or there yet. But we do know there's a lot of genetic and epigenetic reasons that babies might show different signs and symptoms. And I don't think they have to be in it the entire pregnancy to have issues, but we do know that the shorter acting kind of opioids, the baby will withdraw sooner after delivery, especially if a mom kind of tries to stop using those shorter acting ones well before she comes in to deliver. You might even see a baby withdraw like at delivery or shortly after delivery.
Perfect. Thank you so much.
Uh-huh.
Thanks, Cody. I wanted to just ask what you're seeing as, over the last couple of years, we've seen a big increase in methamphetamine use, as well as co-use with methamphetamines and other substances, including opioids. Do you see a different presentation with that neonatal abstinence syndrome among babies who have been exposed to methamphetamines? And if so, how are they treated differently in the hospital setting, or what are the recommendations for parents?
Yeah, there's not a classic withdrawal kind of syndrome associated with methamphetamines in infants. And polysubstance exposure seems to be more associated with severe having signs and symptoms of severe withdrawal. So usually if you see co-use with other substances, that child has a much higher risk of needing treated with a medication. Those are the babies that usually need some adjunctive therapy that they usually need more than just an opioid. So they're usually getting like morphine, methadone, and clonidine. And so that's kind of what I noticed. Definitely an uptick, it seems like, in the amphetamine use, for sure. And maybe a little bit of a downtick in the opiate. I will say maybe a little uptick here in the past couple of months, but overall, I feel like we're treating a lot less neonates in the NICU with medications, and they, at least in our institution, seem to be seeing a little bit less up in the nursery too. I think there's a recent uptick in that, though it feels like it anyway. But yeah, they're more likely to have severe symptoms, more likely to need at least two medications to treat. Does that answer your question?
Yeah, I guess what I had heard when I think about, symptoms that adults experience when they're in withdrawal from stimulants, they obviously want to sleep a lot. So I had heard anecdotally that babies often want to sleep a lot and actually should up to feed because they don't want to go too long without feeding.
Yeah, some people have described that. That's probably been the biggest thing, honestly. I don't know if I've seen that too much at our facility, honestly, but I've heard that throughout the state from providers. That's the opposite of what you expect from an opioid exposed baby. So that is a little bit new and different. Might be interesting to look at, to kind of pull places that take care of these children to see if that's what they're seeing. But I know we talked about that at the state level. When I talked to Stephen Maxwell at Charleston, he said he wasn't seeing that so much either. So it doesn't mean it's not a sign or symptom that people are seeing, because I know it's been talked about that some folks are seeing that, but perhaps it might be the ones that I'm getting in the NICU are the most severe, and the ones that aren't sleeping as much. So those are probably the ones that are still up in the nursery. So that's probably why I'm not seeing it, probably why he's not seeing it, would be my guess. That they're better off because they're sleeping more and probably sticking in their nursery longer, and maybe not coming to us.
Hey, Dr. Smith, this is Dr. Dolan at Marshall. Did I just hear you say you're using methadone and morphine at the same time, or?
No, we just use morphine and clonidine mostly as our two.
Okay.
Yeah.
I misunderstood you then. I just wanted to make sure.
Yeah, it just depends on where you practice.
Any other questions or comments?
I just want to comment. Thank you so much, Cody. I think this information, I always learn something, and I work with moms every day, so it's always really helpful to hear.
Yeah. Hopefully I spun it in their positive direction. I always try, we should be trying to help these families. And I know that's near and dear to your heart, Amanda, and trying to break the stimulation, the stigma pattern, and trying to break this kind of intergenerational problem that we've had. So
yeah, I think it was very positive and very factual and really helpful as we're trying to work with these moms. I think it's important for us to understand all of these different approaches and dynamics and how to manage it. So yeah, I definitely appreciate you.
Absolutely. Thank you. I appreciate all you guys.
Yeah, and when we think about the ways, just during my tenure in working with pregnant women with substance use disorders, so I'm about 12 years into this, what's changed in terms of the treatment of infants? I mean, early on when we had our work group, like we were keeping babies in the hospital for 3 weeks, 2 to 3 weeks was kind of the norm. And now to be able to use non-pharmaceutical interventions or very brief pharmaceutical interventions so that mom and baby can be together and the attachment can occur and the bonding can occur, which is better for management of their symptoms anyway, not to mention, long-term attachment factors that can be impaired or actually improved. Like there's been fantastic successes in that treatment. And then with the Eat, Sleep, and Console that you mentioned, as you said, it's a collaborative approach versus the nurse coming in and telling mom, you go stand over here, I'm going to evaluate your baby and don't look. Literally, I've seen that occur versus welcoming them into the process. Is also a great improvement.
There are states that have made that their standard of scoring, like their scoring standard now. we are moving from our nursery side to Eat Sleep Console. Like any day now, they're rolling this education packet out. We've been working on it for before moving into children's. We've been working on this. I'm helping. The nursery is doing all the hard work, but it's coming very soon. I know Charleston uses it, and so that's actually going to help even more from my standpoint. So there's a question in the chat: do we see a difference with morphine versus methadone length of stay? Yeah, the studies are actually the studies have shown, if anything, that methadone looks superior than morphine. But if you look at some of the studies, they're sending the babies home with morphine or with methadone, excuse me, to taper, and so they're actually on methadone longer, even though their length of stay is shorter. And so, is that right or is that wrong? It's it's debated. It's not recommended for from the AP to send a baby home with medication. We occasionally do it with a very stable family, only to finish that last like day or two at home. But from what studies we have, which aren't very good, methadone looks to be associated with a shorter length of stay. However, some of those studies are sending those kids home with methadone. So when you actually look at it, we found that it seems, at least in our institution, seems comparable. The other thing our institution has been doing since we started is we use a higher threshold score. We don't use scores of 8 from the Finnegan. We've used scores of 12. And we've had no adverse, bounce backs, really, anything crazy from that. And so we use that higher threshold score. But yeah, and then buprenorphine, there's studies out there that show maybe it's the most superior or best out of all of them, but there's been so little research on that so far that we don't know yet either. So really, it's morphine, still morphine or methadone. They're probably easier, and you just do what works best at your institution and whatever your standard approach, your standard protocol calls for. The biggest thing is to standardize it and to be consistent.
I have an observation. So I work with moms that go on to deliver at Hoops Cabell, where Dr. Dolan works. And as a behavioral health provider, the Eat Sleep Console is so empowering for a lot of our moms that are stable and doing well, because they're able to use parenting, their parenting skills and even breastfeeding for most of our women qualify delivery to help to participate in the baby's care. And what I've noticed anecdotally is just a lot more cases where there are pretty short stays, people being discharged after 5 to 7 days, and also mom going home feeling confident and not feeling as guilty and kind of going home feeling like a failure right off the bat.
Yeah, I think it empowers the parent, and it gives us as caregivers, providers, nurses, therapists, social work, and a chance to see that interaction early. But also at the bottom of the Eat Sleep Console tool, there's all those non-pharmacological things to do. That's also teaching that family, that parent, that how to parent right early in this, and giving them the tools to be successful and helping their children succeed early, to grow and to thrive and to be comfortable at home. So that's really is what I like about the tool, more than it just being a simple tool, but just the fact that it involves the parents, and it gives you the opportunity to interact with them together and to give them those tools to succeed.
Any other questions or comments? This has been great. All right, hearing none. Dr. Smith, we really appreciate you taking the time and going through that. Very well done. So thank
Absolutely.
you.
Yeah. My email's here. If you guys think of anything, feel free to reach out to me. Okay.
Okay.
Thanks for having me. I appreciate it.
No problem. So we got about 9 minutes left. We want to use this time to kind of give a little bit of an update of kind of wrapping up the year here for the project, the end of the year, and what to expect coming in 2024. So we have one more session that's going to be on December 11th. So that'll be, the last one for the year. And then what the plan is moving forward is that we have a regular substance use disorder echo that we run that also meets on Mondays. It's just from 4 to 5, but they meet twice a month. And what we'd like to do is kind of combine these groups because there is a lot of overlap in the topics. A lot of overlap in that regular SUD echo does not get enough pregnant and parenting women topics. So we want to sprinkle those in, and then vice versa. We'll have more people to kind of lean on to do some more SUD related topics that kind of cover everything. Doesn't matter if it's pregnant or parenting women or not. So we're going to make that change in 2024. We're going to combine the groups. Again, it'll be at a different time. It'll be on the 2nd and 4th Mondays from 4 to 5 p.m. You are not required to go to both sessions. You can come if you can, great. If you can't in a month, that's okay. That's why we offer it twice a month. We'll have more communications to come out about signing up for those sessions, because those sessions will be in the new iEcho system. So we'll ask you to register. This will hopefully alleviate all the problems where we've had to register every time this echo has happened. That'll all change. That'll all be remedied. So it'll kind of kill two birds with one stone. But we're going to make that change in January of 2024. We will be sending multiple communications out to this group, reminding you and getting you all set up so nothing, everybody's ready to go. But we're going to make that change just because we saw there was a lot of overlap in speakers, topics, things like that. So we're going to try to combine and make it, kind of one overarching echo. Does anybody have any questions on that?
I also wanted to mention, Jay, there is kind of another overlapping training opportunity that does echo. Amanda, you may be familiar with this as well. So Impact West Virginia, they have a Project Scope, which is kind of like an echo. Also, I put that link in the chat, and they talk about supporting children of the opioid epidemic. So many of the lectures are related to things like what Cody just presented on neonatal abstinence syndrome, and anything related to moms and babies who are struggling with substance use disorders, moms who are struggling with substance use disorders, and affected babies.
Anybody else have any questions? We know this is a change. We know, the timing might not always work. So we'll still have our YouTube page. You'll still get the links, so even if you can't come, all the time, please register and that'll keep you in the loop.
So Jay, will there be an email? Will there be an email
yeah.
that gets sent out with the registration link?
Yeah, absolutely. Yeah, we'll be sending that out here after Thanksgiving. We'll send a kind of a summary email that will include the registration and instructions for the new iEcho system, which is a one-time kind of account creation. So yeah, multiple emails really. And then if you guys have any questions while registering, obviously, please let me know. All right, if there aren't any other questions, we'll adjourn till December 11th, still meeting that last time. We'll go over this again as well at that session. So thanks everybody for joining, and we'll see you here in a month. Have a great Thanksgiving holiday.
Thanks, everyone.